Hello and welcome to the lecture on respiratory emergencies. After completion of this chapter and your related coursework, the EMT will be able to understand the significance and characteristics of respiratory emergencies in infants, children, and adults. Students will be able to demonstrate a fundamental comprehension on the following topics: respiratory anatomy and physiology, pathophysiology, signs and symptoms of various respiratory etiologies, for example, asthma, COPD, and pneumonia, and the assessment and management necessary to provide basic care in the pre-hospital setting. Regarding the National EMS Education Standard competencies regarding medicine, the EMT will be able to apply fundamental knowledge to provide basic emergency care and transportation based on assessment findings for a patient who is acutely ill. Regarding respiratory, you'll have an understanding of anatomy, signs, symptoms, and management of respiratory emergencies, including those that affect the upper and lower airways. You will also have an understanding of the anatomy, physiology, pathophysiology, assessment, and management of epiglottitis, spontaneous pneumothorax, pulmonary edema, asthma, and chronic obstructive pulmonary disease, as well as environmental and industrial exposures, toxic gases, pertussis, cystic fibrosis, pulmonary embolism, pneumonia, and viral respiratory infections. EMTs often encounter patients who are complaining of dyspnea or difficulty breathing. This is feeling short of breath or having trouble with your breathing. Dyspnea can be caused by many different conditions. Some of these include asthma, heart failure, pulmonary embolism, or even the common cold. The cause of dyspnea sometimes can be very difficult to determine, and there are several different problems that can contribute to the patient's difficulty breathing at the same time. Even without a definitive diagnosis, you as the EMT may still be able to save a patient's life. Anatomy. The respiratory system consists of all the structures that contribute to breathing, including the diaphragm, chest wall muscles, accessory muscles of breathing, and nerves from the brain and spinal cord to those muscles. We've already gone over these in previous lectures, so this should be a review for you. The upper airway consists of all anatomic structures above the vocal cords, the nose and mouth, and this is where air enters and is filtered, warmed, and humidified. The jaw, the oral cavity, the pharynx, the larynx, and the end of the upper airway. The principal function of the lungs is respiration. Respiration is the exchange of oxygen and carbon dioxide. Air travels through the trachea into the lungs, then on to the bronchi, which are the larger airways, the bronchioles, which are smaller airways, and the alveoli. Alveoli are where there is actual exchange of oxygen and carbon dioxide that takes place. They are very microscopic air sacs, and they are thin-walled. Next, we're going to discuss physiology of respiration. There are two processes that occur, and as I said, this is a review. Number one is inspiration, and that is the act of breathing in or inhaling, and then expiration occurs, and this is the act of breathing out or exhaling. Oxygen is provided to the blood and carbon dioxide is removed from it. In healthy lungs, this exchange of gases takes place rapidly at the level of the alveoli. As you can see from this picture, this is the respiratory process. The alveoli lie against the pulmonary capillary vessels. Oxygen passes freely through tiny air passages in the alveolar wall into these capillaries. It is then carried to the heart, which pumps the oxygen throughout the body. Carbon dioxide then returns to the lungs and it diffuses back into the alveoli. It then is transported back up the bronchial tree and it exits through the upper airways during exhalation. The brainstem monitors the level of carbon dioxide in the arterial blood. If the level of carbon dioxide drops too low, the person automatically breathes at a slower rate and less deeply. As a result, they breathe off less carbon dioxide and the levels then return to normal. If the level of carbon dioxide gets above normal, the person starts breathing faster and deeper, and more carbon dioxide diffuses out of the bloodstream, and the levels in the blood are then lowered. And this is just a picture, again, of blood cells, oxygen and nutrients, and carbon dioxide. Oxygen in, waste out. The proper exchange of oxygen and carbon dioxide can be hindered by abnormal or pathologic conditions in the anatomy of the airway, disease processes, traumatic conditions, and pulmonary vessels which may have abnormalities that interfere with blood flow. As an EMT, you must be able to recognize the signs and symptoms of inadequate breathing. You also need to know how to handle it, what you do about it. Carbon dioxide retention and hypoxic drive. Patients will sometimes have an elevated level of carbon dioxide in their arterial blood. Some of the potential causes of this condition include an exhalation process that may be impaired by lung disease. The body may naturally produce too much carbon dioxide. If levels stay high for a period of years, the respiratory center in the brain may not function properly. It could signify chronic carbon dioxide retention, and if this condition is severe, respiration will stop unless there is a hypoxic drive to stimulate the respiratory center. Patients with chronic lung disease frequently have high levels of carbon dioxide in the blood. In these patients, giving too much oxygen may actually stop their respiratory process. Instead, you should administer low-flow oxygen, but never withhold oxygen from patients who need it. If respiration is slow, then you would just lower the liters per minute. Causes of dyspnea. Dyspnea can be caused by many medical problems. If the brain is deprived of oxygen, a patient may not be alert enough to complain. Altered mental status is more commonly a sign of hypoxia of the brain. Patients often have difficulty breathing and/or hypoxia with the following types of medical conditions: upper or lower airway infections, acute pulmonary edema, chronic obstructive pulmonary disease or COPD, asthma, hay fever, anaphylaxis, spontaneous pneumothorax, pleural effusion, prolonged seizures, airway obstruction, pulmonary embolism, hyperventilation syndrome, environmental or industrial exposures, carbon monoxide poisoning, and infectious diseases. As you treat patients with disorders of the lung, you need to be aware of the following. Gas exchange between the alveoli and pulmonary circulation is obstructed by fluid in the lung, infection, or collapsed alveoli. This is called atelectasis. The alveoli are damaged and cannot transport gases properly across their own walls. The air passages are obstructed by muscle spasm, mucus, or weakened floppy airway walls. Blood flow to the lungs is obstructed by clots, and the pleural space is then filled with air or excess fluid, so the lungs cannot properly expand. Here is Table 13.2 in a synopsis, has a list of signs and symptoms of inadequate breathing, and you should be familiar with these. Besides shortness of breath, a patient with dyspnea may also report chest tightness or air hunger. Dyspnea is a common complaint in patients who have cardiopulmonary disease. Congestive heart failure causes the heart to pump inefficiently and deprives the body of oxygen. And pulmonary edema is a condition associated with congestive heart failure. Severe pain can cause a patient to experience rapid shallow breathing without the presence of a primary pulmonary dysfunction. And in some patients, breathing deeply causes pain because it causes expansion of the chest wall. Upper or lower airway infection. Infectious diseases causing dyspnea may affect all parts of the airway. Some cause mild discomfort, and some obstruct the airway. Oxygenation is a problem of not enough oxygen getting to the tissues. As you can see in these tables, these are information you need to be familiar with based on each of the disease processes. Again, a great synopsis if you would like to take this information and use it as a study guide. The problem causing dyspnea is always based on some form of obstruction. It may be to the flow of air in major passages like colds, diphtheria, epiglottis, or croup, and it can be to gas exchange like pneumonia. As you can see here with epiglottitis, the swollen epiglottis is some type of obstruction. Acute pulmonary edema. Sometimes the heart muscle cannot circulate blood properly. The left side of the heart cannot remove blood from the lungs as fast as the right side delivers it. Fluid builds up within the alveoli and in lung tissue, and this accumulation of fluid is referred to as pulmonary edema. The condition usually results from congestive heart failure. The patient usually experiences dyspnea with rapid shallow respirations. In severe cases, a frothy pink sputum forms at the nose and mouth. Pulmonary edema is a common cause of hospital admission in the United States. Repeat bouts are common. Not all patients with pulmonary edema have heart disease. For example, inhaling large amounts of smoke or toxic chemical fumes can produce pulmonary edema, and traumatic injuries to the chest may also cause it. COPD, or chronic obstructive pulmonary disease. This is a slow process of dilation and disruption of airways and alveoli. It is caused by chronic bronchial obstruction, and it is reported in 12.1 million adults over 25 years of age. It is the fourth leading cause of death, and tobacco smoke is a bronchial irritant and can create chronic bronchitis, an ongoing irritation of the trachea and the bronchi. With bronchitis, excessive mucus is constantly produced, and this obstructs small airways and the alveoli. The airways are weakened as the lungs' protective devices are destroyed, and chronic oxygenation problems can also lead to right heart failure and fluid retention. Pneumonia develops easily, and repeated episodes of irritation and pneumonia cause scarring in the lung and some dilation of the obstructed alveoli, which leads to COPD. Emphysema is another type of COPD. It is the loss of elastic material around the air spaces as a result of chronic stretching of the alveoli. Smoking can directly destroy the elasticity of the lung tissue, and most patients who have COPD have elements of both chronic bronchitis and emphysema. You can see here the normal lung on the left, examples of inflammation or infection and mucus in the airways, and obstruction and infection, and where air gets trapped and the alveoli become dilated. Wet lungs versus dry lungs and cardiac asthma. The wet lung sounds of pulmonary edema and the dry lung sounds of COPD can sometimes be confused. Do not assume that all COPD patients have wheezing and all congestive heart failure patients have rales. Treat the patients, not the lung sounds. Lung sounds are only a symptom. This is a great chart, again, to use as a study guide for the three types of chronic obstructive pulmonary disease, which are emphysema, chronic bronchitis, and congestive heart failure. It briefly has the synopsis of pathophysiology, appearance, level of consciousness, neck veins, skin color, lung condition, lung sounds, blood pressure, cough, and sputum. And you can, again, use this as a study guide. Asthma, hay fever, and anaphylaxis. Asthma, hay fever, and anaphylaxis result from an allergic reaction to an inhaled, ingested, or injected substance. In some cases, we cannot identify the allergen. In asthma, an acute spasm of the smaller air passages or bronchioles occurs. It is associated with excessive production of mucus and swelling of the mucus lining of the respiratory passages. And approximately 22.9 million Americans had asthma in 2007. As you can see here, this is an example of a normal bronchiole and mucus obstructing the bronchiole or narrowed passages in an asthma patient. Asthma affects all ages, but is most prevalent in children between the ages of 5 to 17 years of age. It produces a characteristic wheezing caused by partially obstructed airways. Wheezing is indicative of a partial lower airway obstruction, and it may be so loud that you can hear it without a stethoscope. In other cases, the airways are so blocked that no air movement is heard. Obstruction may be caused by allergic reaction to specific foods or some other allergen. It may also be caused by severe emotional distress, exercise, and respiratory infection. In its most severe form, an allergic reaction can produce anaphylactic shock. It may result in respiratory distress severe enough to lead to coma or death. Most patients with asthma are familiar with their symptoms and know when an attack is imminent. You should listen to the needs of the patient. They often know exactly what they need. Hay fever causes cold-like symptoms, including a runny nose, sneezing, congestion, and sinus pressure. The symptoms are caused by an allergic reaction, usually to outdoor airborne allergens. This includes pollen, dust mites, and pet dander. Patients with hay fever rarely call 911, but they tend to be atopic, meaning they are more likely to have other allergies. Anaphylaxis can produce severe airway swelling, and it is very similar to asthmatic reactions. It is characterized by swelling of the airway and dilation of the blood vessels all over the body, which then lowers blood pressure. The condition is sometimes referred to as anaphylactic shock. The airway can swell so much that it is possible for it to become totally obstructed, and that patients may or may not be aware of their sensitivity to some substances. Therefore, this may be their first anaphylactic reaction. In most cases, epinephrine is the treatment of choice, and oxygen and antihistamines are also helpful. Another great picture here that shows bronchospasm, vasoconstriction, decreased output based on anaphylaxis or an allergic reaction. Spontaneous pneumothorax. Pneumothorax is the partial or total accumulation of air in the pleural space, and it is often caused by trauma. It may also be caused by medical conditions, and this is labeled as spontaneous pneumothorax. This is when a vacuum-like pressure in the pleural space keeps the lungs inflated normally, and when the lung is disruptive, air then escapes into the pleural cavity and the negative vacuum pressure is then lost. The accumulation of air in the pleural space may be mild or severe. A spontaneous pneumothorax occurs in patients with certain lung infections or in young people born with weak areas in the lung. Folks who have emphysema or asthma are at a higher risk, and tall, thin males are also at higher risk. A patient who has a spontaneous pneumothorax becomes dyspneic and might complain of pleuritic-type chest pain. This is a sharp stabbing pain on one side that is worse during breathing or with certain movements of the chest wall. You can sometimes tell that breath sounds are absent or decreased on the affected side. Here is an example of a collapsed lung, as you can see on the right. The lung on the left is fully inflated, the lung on the right is not, and you can now see the pleural space and the site of the wound in the upper lobe of the lung. Pleural effusion is a collection of fluid outside the lung. It then compresses the lung and causes dyspnea. It can stem from an infection, congestive heart failure, or cancer. And patients feel better if they are sitting upright. You can see in this picture pleural effusion in both sides of the lung. It's the grayer area here. Found here and here. Prolonged seizures. A seizure is a disruption in the electrical activity in the brain. In a tonic-clonic seizure, formerly we called this a grand mal seizure, the patient had a sudden loss of consciousness, had tonic-clonic movements of the body, and is often incontinent. In most cases, the seizure will only last a few minutes, and the patient will then regain consciousness. However, there are cases where the patient continues to have seizures every few minutes without becoming conscious. This is called status epilepticus and could be life-threatening. During a brief seizure, the patient may have impaired breathing. In a prolonged seizure, the other airway issues emerge. The patient will have no control over their airway while they're unconscious, and blood and saliva can then be aspirated down into the airway. If the patient is on their back, the tongue can also block the airway, and the constant muscle contractions can interfere with the chest's ability to expand, and the patient will hyperventilate and become hypoxic. The patient may also become apneic, and other effects of a prolonged seizure include hyperthermia, dehydration, and hypoglycemia. Airway obstruction. A patient who has dyspnea may have a mechanical obstruction. This needs to be treated quickly, and in the semi-conscious or unconscious patient, the obstruction may be the result of aspirations of vomitus or a foreign object, or improper positioning of the head causing the tongue to block the airway. If the patient was eating just before onset of the dyspnea, always consider the possibility of a foreign body airway obstruction. You can see this on the left, and on the right you can see the unconscious patient lying on their back who has the tongue now obstructing their airway. Pulmonary embolism. An embolus is anything that moves from its point of origin to another place in the body which obstructs subsequent blood flow. Circulation can be cut off completely or partially, and the emboli can result in a serious life-threatening condition. Emboli can be fragments of blood clots in an artery or vein that break off and travel through the bloodstream. They can also be foreign bodies that enter the circulation, such as a bubble of air. A pulmonary embolism is the passage of blood clots through the venous system. It may be the result of damage to the lining of the vessels, a tendency for blood to clot unusually fast, slow blood flow in a lower extremity, or slow blood flow in the legs that is often the result of long-term bed rest. You can see the picture of a blood clot lodging in a pulmonary artery here. Here you can see it traveling from the leg up through the heart into the pulmonary artery of the lung. We'll watch it one more time. Signs and symptoms of a pulmonary embolus include the following: dyspnea, also known as difficulty breathing, acute onset of chest pain on the side of the clot, hemoptysis, which is coughing up blood, cyanosis, or bluish tinge to the skin, tachypnea, rapid breathing. Some varying degrees of hypoxia may also occur. If the embolism is large enough, there may be complete obstruction of the output of blood from the right side of the heart, and this can result in sudden death. Hyperventilation. Hyperventilation is best defined as overbreathing to the point that the level of arterial carbon dioxide falls below normal, and this can be an indicator of a life-threatening illness. Acidosis is the buildup of excess acid in blood or body tissues. Alkalosis is the buildup of excess base or lack of acids in body fluids. This can cause symptoms of hyperventilation syndrome or panic attack, which include anxiety, dizziness, numbness, tingling of the hands and feet, a sense of shortness of breath, and despite their rapid rate of breathing. The decision whether hyperventilation is being caused by a life-threatening illness or a panic attack should not be made in the pre-hospital setting. You should verbally instruct the patient to slow his or her breathing, and if that does not work, give them supplemental oxygen and transport. We do not have patients breathe into a bag. Carbon monoxide. We're going to talk about environmental and industrial exposures here. Pesticides, cleaning solutions, chemicals, chlorine, and other gases can be accidentally released at industrial sites. Carbon monoxide is produced in industrial settings by vehicles, gasoline-powered tools, and heaters. It is odorless and highly poisonous, and any exposed patient needs to be decontaminated and receive medical care. After decontamination of the patient occurs, you should gather information about whatever substance and the cause of shortness of breath. You should pay special attention to the patient's lung sounds, because inhalation injuries may cause serious lung damage. Carbon monoxide poisoning is the leading cause of accidental death in the United States, and people who have it complain of flu-like symptoms and dyspnea. High-flow oxygen by non-rebreather mask is the best treatment for conscious patients of carbon monoxide poisoning, and of course you must remove them from their environment. Bacterial and viral respiratory infections. The ones we want to talk about specifically are MRSA, which we've already discussed previously, and TB. MRSA is a bacterium that causes infections in different parts of the body. It is transmitted by different routes, including respiratory, and it is difficult to treat. It often affects people who have weakened immune systems in hospitals and nursing homes. TB is a bacterial infection that most commonly affects the lungs. It can also be found in almost any other organ. It can remain inactive for years before it produces symptoms, and the patients often complain of fever, coughing, fatigue, night sweats, and weight loss. The prevalence is higher in the homeless population, prison inmates, and nursing home residents, and it is also found in persons who abuse intravenous drugs or alcohol, or those with HIV. Patient assessment. The patient assessment steps are always the same. You're going to hear this for the rest of this semester. We always want to do our scene size up, perform a primary assessment, take a history, then perform a secondary assessment, and then reassess our patients during transport. Scene size up. For scene safety, we always use standard precautions, use the proper PPE, consider the possibility of a toxic substance exposure, and also consider the potential for violence. We need to look at the mechanism of injury or nature of illness, and if in question, ask the patient why 911 was called. The nature of the illness is often based on a history of chronic medical problems. We want to identify immediate life threats. We want to note problems with the airway, inhibitions of normal breathing, and issues preventing normal circulation. We want to form a general impression. Form an overall general impression of the patient's level of distress, including getting their age, their anxiety, and body positioning. This will help you assess them. We want to use AVPU to develop or to check their neurostatus. We look for alert to person, place, time, and event, responsive to verbal stimuli, responsive to pain, or unresponsive. Airway and breathing assessment. You should make sure the airway is patent and adequate. If there is any question about patency of the airway, you must open it immediately using head tilt, chin lift, or jaw thrust. Determination of breath sounds is important, and you need to know if they are normal or not. It is very important that you assess every patient's lung sounds so that you learn normal so that you can recognize abnormal. You should assess the rate, rhythm, and quality of respirations. Ask or listen for snoring sounds in an unresponsive patient, as you may need to insert an oral or nasal airway. Ask yourself the following questions. Is air going in? Does the chest expand with each breath? Does the chest fall after each breath? Is the rate adequate for the victim's age? Determine whether breath sounds are normal, whether they're vesicular or bronchial, or decreased, absent, or abnormal, which are adventitious breath sounds. You want to listen for a full respiratory cycle. And abnormal sounds include wheezing, rales, rhonchi, and stridor. And this picture shows you where you should place your stethoscope to listen to lung sounds. You should then assess circulation. Assess the pulse rate, quality, and rhythm. Tachycardia is an increased pulse rate and is normal response to pain, fear, excitement, and exertion. Bradycardia is a decreased pulse rate and could mean problems with the cardiac conduction system, medication reaction, organophosphate poisoning, or decompensation. Is the pulse strong, bounding, or weak? Is it regular or irregular? You should evaluate for shock and bleeding. Assess perfusion by evaluating skin color, temperature, and condition. Reassess and identify life threats in your patient. They would include any of the following signs or symptoms: problems with the airway, breathing, and circulation, a poor general initial impression, unresponsiveness, potential hypoperfusion or shock, chest pain associated with a low blood pressure, severe pain anywhere, or excessive bleeding. You then want to make your transport decision. If your patient's condition is unstable and there is the evidence of a possible life threat, you address the life threat and proceed with rapid transport. History taking. We always should investigate our patient's chief complaint. Objective and subjective observations are important in building a general assessment. Different respiratory complaints offer different clues and different challenges. With patients in respiratory distress, a sample history can be collected from bystanders or family if they are present. And you should be sure to ask the following questions about a patient in respiratory distress. What is the patient's general state of health, and has the patient had any childhood or adult illnesses? Ask about any surgeries or hospitalizations. Ask about psychiatric or mental health issues. And ask about traumatic injury. You should use the OPQ RST assessment to assess for pain and gather information about the problem breathing. When did it start? What makes the breathing difficulty worse or better? How does it feel? Does the discomfort move? Meaning, does it radiate? For quality, is it sharp or dull or whatever? How much of the problem is the patient having? How severe is it on a scale of 1 to 10? Is the problem continuing or intermittent? This is time. If it is intermittent, how frequently does it occur and how long does it last? We also use the PACE assessment specific for an alternative assessment with difficulty breathing. Progression, associated chest pain, sputum, are they coughing anything up? Do they get tired by talking, or can they move about? Do they have exercise tolerance? Secondary assessment. The secondary assessment is more in-depth assessment of body systems. You should only proceed with a secondary assessment if life threats have been addressed and treated. Physical exam. Look for signs of COPD. Patients with COPD are usually older than 50, have a history of lung problems, are almost always long-term smokers, complain of tightness in the chest and constant fatigue, often use accessory muscles to breathe, and exhibit abnormal breath sounds. Check vital signs. You want to check and compare distal pulses, reassess skin condition, and be alert for tachycardia and bradycardia, and check the patient's mental status. You should use appropriate monitoring devices such as pulse oximetry, and realize that this does measure the percentage of hemoglobin that is saturated by oxygen. When we reassess our patients, the things we need to be familiar with and think about include repeat of the primary assessment. You need to determine if there have been changes in the patient's condition. You also should confirm the adequacy of interventions and patient status. If the patient's condition is stable and no life threats exist, vital signs should be obtained at least every 15 minutes. Interventions for respiratory problems may include providing oxygen via a non-rebreather mask at 15 liters a minute, providing positive pressure ventilation with a bag mask device, a pocket mask, or a flow-restricted oxygen-powered device, using airway management techniques such as an oropharyngeal airway, nasopharyngeal airway, suctioning, and airway positioning, positioning the patient in a high Fowler's position or position of choice, assisting the patient with respiratory medications. Communication and documentation. You must communicate all relevant information to staff at the receiving hospital and provide appropriate documentation as well. Emergency medical care. Management of respiratory distress. If a patient complains of difficulty breathing, you should administer supplemental oxygen immediately. You should take great care in monitoring respirations. You should reevaluate respirations every 5 minutes. You should not withhold oxygen in patients with COPD. The patient may have a metered-dose inhaler or a small volume nebulizer, and you may have to help the patient administer the multi-dose inhaler or the small volume nebulizer, and there are skill drills for this. You should consult medical control and make sure the medication is indicated.
As an emergency responder, you may need to administer medication to a patient with a bronchodilator metered dose inhaler, also referred to as an MDI. MDIs are miniature spray canisters used to dispense medication through the mouth and into the lungs. The medication helps open the airway.
Hello, sir. My name is Brandon. What seems to be the problem?
I don't know. I just become short of breath. I was mowing the lawn here. I don't know what happened.
Do you have any allergies to any medicines?
No.
Have you ever been to the hospital before?
Just for previous asthma attacks.
Okay, so you have a past medical history of asthma?
Yeah.
Okay, what was the last thing you had to eat?
I don't know. I had dinner probably a couple hours ago. I had a cheeseburger.
And I take it you were mowing grass before this all started?
Yep.
Okay. My partner's going to take your vitals here, and I'm going to give the hospital a call to see what we can do for you.
Okay.
Emergency Hospital, this is EMT Ward, Northwest EMS Medic 197. I have a 38-year-old male patient with possible asthma attack requesting permission to administer 1 dose albuterol.
Repeat the order given by the physician.
Okay, I'm going to administer 1 dose albuterol.
From the medication box, choose the correct medication as ordered by the physician. Inspect the medication label for the correct name and appropriate concentration. Verify that the expiration date has not passed. Actively shake the inhaler several times.
Okay. I have albuterol here. This is going to help you breathe better. What I need you to do is take a deep breath and then exhale. And you're going to take another deep breath, and I'm going to give you a dose of this. And you're going to hold that breath as long as you comfortably can, and then exhale for me, okay?
Yeah.
Okay.
Monitor the patient by reassessing vital signs, tissue color, and difficulty breathing to determine the effects of the medication. As an emergency responder, you may need to open the airway of a patient with respiratory illness, like asthma, by using a small volume nebulizer. Nebulizers have 3 main parts: a cup that holds the medication, a mouthpiece or mask attached to a T-shaped part, and a thin plastic tube that connects the mouthpiece to the compressor. Use appropriate body substance isolation prior to beginning the patient care. Repeat the order given by the physician. Repeat the drug dosage, route, and any additional special considerations. This important first step maintains the 6 rights to drug administration: right drug, right patient, right dose, right route, right time, and right documentation. Inform the patient of the order received, the need for therapy, and any concerns about its administration. Ask whether the patient is allergic to the medication ordered or to any other drugs, iodine, or foods.
I'm going to give you an albuterol treatment.
Open the nebulizer and add the ordered volume. This is normally the entire amount in the container, but mixing the medication with sterile saline or using partial doses may be necessary. Reassemble the nebulizer and attach the mouthpiece and exhaust tube. Connect the oxygen tubing to the nebulizer and the oxygen regulator. Adjust the oxygen flow to achieve the desired misting effect, usually between 6 and 10 liters per minute, and wait for a slight mist to come from the end of the tube. Instruct the patient to place the nebulizer to the mouth and breathe normally, inhaling the mist. Monitor the patient by reassessing vital signs, tissue color, and difficulty breathing to determine the effects of the medication.
It is important that you ensure that there are no contraindications to the patient condition to use either the MDI or the small volume nebulizer. The things we look at is the patient unable to help coordinate inhalation. The MDI or small volume nebulizer is not prescribed for this patient. You did not obtain permission from medical control. It is not permitted by local protocol. The patient has already met the maximum prescribed dose, the medication is expired, or there are other contraindications specific to this medication. Some common side effects of inhalers to keep in mind are that they do increase the pulse and heart rate, they may cause nervousness and muscle tremors. We're going to talk about some treatment of specific respiratory conditions pretty quickly. These are things for you to be aware of, and this will help you in your assessment and treatment process. For upper or lower airway infections, if possible, you should provide humidified oxygen, position the patient comfortably, and transport promptly. Children who are experiencing an upper airway obstruction from epiglottitis will probably sit up in a tripoding position or the sniffing position. They have trouble swallowing and trouble breathing, so laying down does not work well for them. Acute pulmonary edema. You should provide 100% oxygen, suction if necessary, position comfortably, and transport promptly. Chronic obstructive pulmonary disease. You can assist with the prescribed inhaler. Be sure you watch for side effects due to overuse, position them comfortably, and transport promptly. For asthma, hay fever, and anaphylaxis, you should, for asthma, assist the patient with their inhaler. First of all, you need to determine if asthma is really the problem before you assist and provide aggressive airway management, oxygen, and prompt transport. Patients with hay fever are unlikely to need emergency treatment, but if they do call you, you should manage their airway and give oxygen according to their level of distress. Anaphylaxis, you should remove the offensive agent, maintain their airway, provide rapid transport, and if it is allowed by local protocol, administer epinephrine. Spontaneous pneumothorax, provide supplemental oxygen, transport promptly, and monitor carefully. Pleural effusion. The fluid removal for this must be done at the hospital. You need to provide oxygen and transport promptly. Prolonged seizures. The patient needs to reach the hospital quickly, or you need to call for an ALS intercept to reach you quickly. When the seizure ends, you need to provide aggressive airway management and transport rapidly to the emergency department. Airway obstruction. With a partial obstruction, you should provide supplemental oxygen and transport. If your patient has a complete airway obstruction, you must clear the obstruction and administer oxygen. All patients with airway obstruction need to be transported to the emergency department. Pulmonary embolus. Supplemental oxygen is mandatory. You should position them comfortably, and if they are experiencing hemoptysis, clear the airway immediately, and then provide prompt transport. Hyperventilation. Complete your primary assessment and get your history. We never have patients breathe into a paper bag. Provide supplemental oxygen and transport. Environmental or industrial exposures. Ensure that the patients are decontaminated. Treat them with oxygen adjuncts and suction based on their presentation, and always provide transportation rapidly. Epidemic and pandemic considerations. An epidemic is defined as a substantial new case of a disease occurring. A pandemic is an outbreak on a global scale. Pandemic examples are H1N1 influenza A. It's an infection that's transmitted by direct contact with nasal secretions and aerosolized droplets from coughing and sneezing by infected patients. You should be compliant in wearing your PPE, wash your hands frequently, and maintain your vaccines. Next, we're going to talk about some age-related assessment and management issues. For foreign body aspiration, this is when an object is aspirated into a lung and is very common in young children who put everything into their mouths. Most deaths occur from foreign body aspiration in patients under the age of 5, and we need to try to clear the airway. If it's blocking, provide oxygen and transport rapidly. Elderly patients may have weakened airway musculature and a decreased cough and gag reflex and make it difficult for them to clear their airway. Dysfunction of a tracheostomy. Tubes can become obstructed by secretions, mucus, or foreign bodies. Bleeding, leaking, dislodgement, and infection may also be issues. You need to position them comfortably, provide suctioning to clear the obstruction, and once it is clear, oxygenate your patient. Croup. Inflammation and swelling of the pharynx, larynx, and trachea. This is typically seen in children between the ages of 6 months and 3 years, and it is easily passed between children. Croup often responds well to the administration of humidified oxygen. Epiglottitis. Inflammation of the epiglottis as the result of a bacterial infection is epiglottitis. It is more predominant in children, but it may occur in the elderly. You should treat children gently and try not to make them cry. Position them comfortably, give them high-flow oxygen, and never put anything in their mouths. Asthma. It is a common childhood illness, and you need to keep in mind that a cough is not always a symptom of a cold. It could signal pneumonia or asthma. Provide blow-by oxygen by holding the mask in front of the child's face, and use inhalers just as you would with older patients. As with any chronic disease, asthma may be life-threatening in an older patient. Bronchiolitis. Bronchiolitis is a viral illness that usually affects newborns and toddlers. It is often caused by RSV, and the bronchioles become inflamed, swell, and then fill with mucus. Pneumonia. Pneumonia worldwide is the leading cause of death in children, and it is often a secondary infection, and it begins after the patient has had an upper respiratory tract infection. Bacterial pneumonia will come on very quickly and result in high fever. Viral pneumonia, on the other hand, presents more gradually and is less severe. Pneumonia especially affects people who are chronically and terminally ill, and the signs and symptoms of pneumonia include exertional dyspnea, productive cough, chest discomfort and pain, wheezing, headache, nausea and vomiting, musculoskeletal pain, weight loss, confusion, cyanosis and pallor, dry skin, possible fever, decreased skin turgor, and pale dry mucosa. You need to obtain a core temperature to determine the presence of fever, and treat with airway, ventilatory, and circulatory support. Pertussis or whooping cough. It's an airborne bacterial infection, and it most often affects children under the age of 6. It is highly contagious and is passed through droplet infection, and you should watch for signs of dehydration in these patients. It may be necessary for you to suction their airway. Cystic fibrosis is a genetic disorder that affects the lungs and digestive system. It often causes death in childhood, and you need to suction and oxygenate as needed. Congestive heart failure. Risk factors include hypertension and a history of coronary artery disease and/or atrial fibrillation. In most cases, patients have a long history of chronic congestive heart failure. The signs and symptoms may include difficulty breathing, respiratory distress, cough, a feeling of suffocation, cold sweats, and tachycardia. Your treatment should consist of airway, ventilatory, and circulatory support, and you should provide high-flow oxygen. EMTs may be able to use continuous positive airway pressure or CPAP in a non-invasive means of providing ventilatory support if the patient can tolerate it. In summary, dyspnea is a common complaint that may be caused by numerous medical problems. Some of the causes of dyspnea include upper and lower airway infections, acute pulmonary edema, chronic obstructive pulmonary disease, spontaneous pneumothorax, asthma, allergic reactions, pleural effusion, mechanical airway obstruction, pulmonary embolism, and hyperventilation. Lung disorders can interfere with the exchange of oxygen and carbon dioxide that occurs during the process of respiration. This interference may be by damage to the alveoli, separation of the alveoli from the pulmonary vessels by fluid or infection, obstruction of the air passes, or excess fluid in the pleural space. Patients who have long-standing lung diseases often have chronically high levels of blood carbon dioxide. Giving too much oxygen to patients who have this may depress or stop their respiratory drive. Judicious use of oxygen is always an important priority in patients who are having dyspnea. Patients often develop breathing difficulty and/or hypoxia with upper or lower airway infection. Also, acute pulmonary edema, chronic obstructive pulmonary disease, hay fever, asthma, anaphylaxis, spontaneous pneumothorax, and pleural effusion. Infectious diseases associated with dyspnea include epiglottitis, bronchitis, tuberculosis, pneumonia, and pertussis. Lung and breath sounds are some of the most important vital signs the EMT should assess when treating a patient in respiratory distress. Signs and symptoms of breathing difficulty include wheezing, stridor, rales, rhonchi, nasal flaring, pursed lip breathing, cyanosis, inability to talk, use of accessory muscles to breathe, and sitting in the tripod position. Interventions for respiratory problems may include providing oxygen via a non-rebreather mask at 15 liters a minute, positive pressure ventilations using a bag mask device, a pocket mask, or a flow-restricted oxygen-powered ventilation device, providing airway management techniques such as using an oral or nasal airway, suctioning, or positioning, position in a high Fowler's position or a position of comfort to facilitate breathing, assisting with respiratory medications found in a prescribed MDI or a small volume nebulizer. Remember, if your patient is breathing rapidly, they may not be getting enough oxygen as a result of respiratory distress from a variety of problems. The problems include pneumonia or a pulmonary embolism, trying to blow off more carbon dioxide to compensate for acidosis caused by a poison, severe infection, or a high blood glucose level, or having a stress reaction. In every case, prompt recognition of the problem, administration of oxygen, and prompt transport are essential in treatment of our patients. Thanks for paying attention during this lecture. I hope you took notes, and as I said, if you have questions, bring them to class to discuss with your instructor.